Management of gestational diabetes mellitus. That is what we are going to talk today. Kindly make sure you subscribe. It will cost you absolutely nothing. Management. So we have two goals of management. That is the glycemic control and the delivery. So before we start, I'm just going to remind you the pathophysiology behind gestational diabetes. So in terms of the pathophysiology, in a pregnancy, we have the hormones that we produce: insulin, progesterone, human lactogen, so human placental lactogen. All those hormones antagonize insulin. So the body is kind of like a wall. So when something happens, it counteracts. So normally the pancreas secretes 3 times the normal insulin. So when this does not occur is when we have gestational diabetes. So in terms of the glycemic control, so when you need to have that picture behind your head for you to manage this for you to manage this diabetes. So the first thing we need to do glycemic control. In terms, we start obviously with the diet, where you avoid complex carbohydrate, calorie restriction, and carbohydrate restriction. The second thing is obvious exercise. We advise the patient to do aerobics. The third, obvious in terms of the glycemic control, obvious in addition to the oral medication, insulin is also required up to 20%, because as I mentioned before in the pathophysiology, that insulin is supposed to be produced by the pancreas at least 3 times. So when it is not produced by the pancreas, then we have gestational diabetes. So in terms of delivery, if no insulin is required and we have good glycemic control, then you await labor. However, if you use insulin and it is required, or you have complications such as preeclampsia, macrosomia, polyhydramnios, then you consider to deliver at 3 weeks via elective CS or induction. So those are our two goals. When you already have these goals in our picture, then it will be very easy to cruise through the slides. So when you're managing a patient, you need to have goals. Even in your life, you need to have goals. When you're doing something, you need to have goals and targets. So the same thing here. As much as we are advising the patient to live healthily, we need to monitor blood glucose regularly and aim. So this aim, we will have our fasting blood glucose at less than 5. We'll have our pre-meals at less than 6, and 1 hour postprandial less than 7.8, and 2 hours postprandial less than 6.7. So this is very key, because you just don't come and say this is our target and do nothing about it. You tell the patient you will be measuring your home glucose and these days and these times per day, and then when you come to clinic you bring the paper, and then now we look, have you improved? What can we do? Can we increase the insulin? Can we remove this drug? Can we increase this drug? So in terms of, if the blood is not optimized within 2 weeks, obvious, of eating healthy and exercise, then you put the patients on oral glucose drugs that include metformin or insulin. 15 to 30% of the patient will require insulin, as you said before. Then follow up is similar for the patient with diabetes and pregnancy. Then we said you deliver at 38 weeks is advised if the sugars are well controlled, and if they are poorly controlled, then you see a specialist to advise on the timing. Consider steroid administration for lung maturation if you want to go for surgery. So if you want to deliver early. So can we consider that the steroids will alter glycemic control? So if steroids are administered at any point in pregnancy and anticipate difficult glycemic control, and insulin therapy should be advised. So the target during labor and delivery should be 7.4 to 7 millimoles per liter. And also anticipate fetal and maternal neonatal complication of delivery and plan for necessity intervention. So in terms of postpartum care, we don't just plan antenatal and plan interpartum. We also plan postpartum care. So you monitor the blood glucose postpartum care. If the blood glucose goes above 7.8, that is 126, or this is random, and fasting blood glucose 6.1 post delivery, you manage a pre existing diabetes. So I have delivered, and then after I have delivered, you take my blood glucose. So if the random is 7.8 or greater and the fasting is 6.1, you manage me like a patient who had already had diabetes before pregnancy. If blood glucose are normal post delivery, then you repeat your oral glucose tolerance test with 75 glucose at 6 weeks. Kindly note, at 6 weeks, to exclude diabetes mellitus or insulin impaired glucose tolerance. So if at 6 weeks, then this is normal, you encourage the patient to do an annual fasting blood glucose thereafter. In addition to that, you counsel the patient on risk of gestational diabetes or diabetes, because one of the risk factors of gestational diabetes that this patient, if she had diabetes during this pregnancy, the probability of having gestational diabetes in the next pregnancy is high. Encourage the patient to exercise, to have proper diet and normal BMI. In addition to that, you encourage the patient to use contraception at 6 weeks, so that we cannot like so that the patient can plan the pregnancy and not have these complications. So in terms of prognosis, nearly 50% of the women with gestational diabetes develop overt. Overt diabetes is when now you already have like diabetes or pre-existing diabetes of a follow-up of 5 to 20 years. So women with fasting hyperglycemia, that is when they have elevated blood glucose, that have got worse prognosis to develop type 2 diabetes and cardiovascular complication. As I said before, the reoccurrence risk in subsequent pregnancy is more than 50%. And the infants will have the following complication. They'll have a risk of being overweight, that is type times 2 risk, and they will have a risk of metabolic syndrome, that is times 4 risk.